Welcome everyone to this Meet the Trialist session at ESC TV in Barcelona 2022. We will discuss the DANFLU-1 trial, which was presented here earlier today as a hotline session. I am Ole Frobert. I'm invasive cardiologist in Örebro University Hospital in Sweden and a professor there and at Aarhus University in Denmark. I'm joined here today by the principal investigator of DANFLU-1, Niklas Johansen, and the senior investigator, Biering-Sorensen, both from Copenhagen University Hospital in Denmark. Welcome both of you, and I think if we could start off, perhaps Niklas, if you would just briefly remind us what was the main objective of DANFLU-1 and what was the take-home main finding?
Yeah, so DANFLU-1 was a pragmatic, randomized, open-label, active-controlled feasibility trial of two influenza vaccines, a standard dose and a high-dose vaccine. And the primary objective was to evaluate the feasibility of conducting a trial of influenza vaccines within routine vaccination practice and using administrative health registries for all data collection, including both baseline, outcome, and safety data. And what we found was that we ended up recruiting 12,500 participants, most of them in only 2 weeks. And we found that the design of the trial was feasible. And also we found some significant findings with regards to clinical endpoints that should of course be considered hypothesis generating, since the trial was not powered for these outcomes. We found reductions in hospitalization for influenza or pneumonia and all-cause mortality with high dose compared with standard dose.
Thank you very much, Niklas. It really was quite an endeavor with this trial with so many patients and in such a short time span. I think perhaps we should remind the audience why influenza is of interest at a cardiology conference. What we know about influenza is that there is an association between association and cardiovascular outcomes. So when there's influenza in society, we have more patients that come into hospital with a number of cardiovascular diagnoses, MI especially, but also heart failure and stroke. And we have, I think, hundreds of observational studies supporting this, and we have 4 randomized clinical trials indicating that influenza vaccine is protective against cardiovascular events. So if you should take just the take-home message, maybe Tor, if you say, what's the home message of this fast, huge trial?
So, as Niklas mentioned, it was a feasibility trial. So the main objective of the trial was to test whether it's feasible to conduct giga trials in a nationwide register-based way. And I think the main take-home message from this trial is that it is possible, and that was the purpose of doing it. That was the thing we want to test. Of course, we also, because we get the endpoints for free in this system, we also wanted to assess hypothesis-generating associations, whether we could see a signal. But as Niklas also mentioned, they are only hypothesis-generating, the findings about the hospitalizations that we saw, and also the finding on all-cause mortality, because the study wasn't powered for that. We designed the trial to test whether it's possible, so we now can move on to do a sufficiently powered trial where we actually can assess whether high-dose influenza vaccine significantly lowers the risk of hospitalizations as compared to standard dose vaccine.
So the trial was obviously done in a Scandinavian country, a well-organized society, but what obstacles did you meet when you organized the trial? What were the main obstacles?
First of all, before we started the trial, we were actually not sure whether we would be able to get regulatory approval for some of these items with regards to the registry-based data collection. and some other pragmatic elements in the trial. So that was of course an obstacle, but we worked closely with the authorities on that and found.
And they were positive?
Yeah, they were actually. They have an interest in conducting pragmatic trials as well. So that was a positive experience for us actually.
But you mentioned there was a delay when you did your hotline. What kind of delay? What was the cause?
You want to go?
That was exactly that. We were delayed because we needed the approval, and the approval came, on the week of initiating the trial. So that was exactly in those correspondences with the authorities. However, we started planning the trial quite late in the process because this was conducted during COVID, and we discussed with the funder, how much should we bet and how many vaccines should we use, because we didn't know whether we would have influenza circulating at all in this season. So we also started late, but it was also the discussions with the authorities that, of course, we went back and forth because this is the first trial in Denmark using completely safety monitoring as we did, only using the registries. But you might have some.
Yeah, and always when integrating something into like a routine official vaccination program, for example, there will always be late-minute changes to that, and so that was why we had to submit an amendment for the protocol that we have to get approved in the 11th hour before we could actually initiate recruitment for the trial.
Must have been stressful.
Yeah.
So when we consider the results, how far are we? Could we say now 65-year plus patients should have this vaccine? You mentioned we need a trial powered for hard endpoints. Can we say anything?
I think that in the original New England Journal of Medicine paper, it showed that it's in adults above 65 years, influenza infection was reduced by 24%. But how that translates into reductions in hard endpoints with regards to effect sizes would still need to be investigated to provide further evidence for cost-effectiveness analysis, for example.
And I just want to add that we already know from the original publication in 2015 that it protects better against the flu. So if we just want to look at that, whether preventing a flu infection, then we should go with the high dose vaccines. That's a given because we know that.
Yeah.
But of course, as Niklas mentioned, we don't know on a population level how cost effective it is because they are a little more expensive, right? The high dose vaccines than the standard doses.
So I guess an obvious question here is, now we talk about cost. So perhaps we could, how much more expensive is high dose vaccine compared to the standard dose? Just in percent?
I think during the season that we conducted it was around a 2.5-fold increase from the standard dose to the high dose. I think in euro, maybe around 10 euro for a standard dose and 25 for a high dose, in Denmark at least, but I think it could vary very much from country to country, depending on how you buy your vaccines and what agreements you're able to make.
If we look at your results, if we could halve number of deaths, it sounds inexpensive.
Yeah.
But if we could prevent a little flu, it sounds expensive.
Exactly.
But another feature of cost, you did your trial as a pragmatic trial, a registry-based randomized clinical trial. So you collected, as you told us, all your baseline safety and outcome variables from registries. Can you give us just a ballpark figure? How much did you save in your conduction of the trial compared to if this had been a conventional randomized clinical trial? In euro or in percent?
So it's not to go into details about the exact cost. Of course, that is one of the main drivers of why we need to do trials. Both the fact that we can randomize huge amount of people, but it is for a much lower cost. But I'm not certain about how much the cost was for the trial that Sanofi conducted in 2015. I have no idea. But our trial can, using this system, we can get close to, just one digit of millions of dollars for conducting a trial, right? So, but I'm not certain how much a regular trial costs, but I know that it's much more than what we can do when using these registries, right?
Yeah. If you should comment on the limitations of the trial, what are the major limitations as you see them? Now, I criticized your trial, I think gently at the hotline, but what do you think are the most important limitations of this trial design in your trial?
Yeah, so you could say that it was open label, for example, but when looking at hard clinical outcomes, that might not matter that much, as you also said during your appraisal of the study. And there, of course, there are the caveats with regards to the hypothesis generating outcome results that we found. But also using the registries for data collection, we need to do validation studies. Even though we didn't validate and will not validate outcomes probably for a larger trial, we need to be sure what we are actually looking at. What is the effect? What is it actually on? Because we have our diagnosis codes from the registries, but we need to know.
And how good are they? Do you know?
Yeah, they're generally very, very good. A lot of validation work has been done, mostly in the cardiovascular endpoints in Denmark, and those almost always have positive predictive values of above 90%.
Okay.
So, yeah. But also another thing is, do we miss any events by using these codes? Yeah.
Yeah. Now, there is this, you mentioned yourself, if you should do a full-powered trial, and you even did a publication prior to this trial where you calculated how many, if you do it in a citizen-based setting, how many patients you would need or citizens you would need to conduct a trial powered for hard clinical endpoints. And there were figures between 100 and 200,000 citizens. Is the trial coming?
The trial is actually planned to be initiated this season. But a lot of structural things has happened during the COVID pandemic. So the whole administration of flu vaccines has changed in Denmark. Previously, all pharmacies, all private companies that wanted to vaccinate could vaccinate and then get reimbursed. Now, due to the COVID pandemic and due to the experience that the health authorities in Denmark had with COVID vaccines, they've chosen to take all of the vaccines and administer them directly through the governmental hospital system. So we are currently discussing with the authorities what this actually is going to mean for conducting our trial. Because as Niklas presented this morning, the trial was conducted in collaboration with a private vaccine company.
Yeah.
That maybe will not be allowed to vaccinate this year. So we are in discussions with the health authorities, and that might be one of also the limitations of conducting a trial like this specifically with vaccines, when you embed it in the nationwide vaccine strategy, that you are deemed to follow whatever rules or changes that they do in the health authorities, and that can change very rapidly during a pandemic like we just experienced. So it was in June that it was public that the whole vaccination, the whole flu vaccination strategy would change. We have been working, tirelessly since June to figure out, what that means for our trial, if we can embed it then at the hospital vaccine sites. But that's, So it was actually planned to be initiated this year, but we will start it this year, but we don't know how many we'll be able to randomize. So the goal of randomizing 208,000 from the get-go, it might be difficult this year, but the good thing is, or the bad thing is, the flu circulates and comes back every year, so we have a couple of years to do the trial.
Yeah, so if this materializes, is it Is the plan to do it in one season?
No,
No.
the plan was 2 seasons,
Yeah.
104,000 participants randomized each season, and the largest individually randomized trial conducted.
Maybe we should also let, if there are any questions from the audience, there will come a microphone up here in the center. So if you would like to ask a question to the DANFLU-1 investigators, please step forward to the microphone and introduce yourself and ask a question. Don't be shy.
Ole, in the meantime, I might just add that one unique thing about the DANFLU-1 trial was also the fact that we invited 34,000. That was the amount that we invited through email, and 1/3, almost 12,500, wanted to participate in the trial. That's also unique for this trial. That's not been seen, in other trials.
Yeah.
That many actually want to participate in a trial like this. So that's also, why we believe it's possible to get the numbers of 208,000 to participate in this trial.
But perhaps with influenza vaccine, you have an advantage that it's just one flu jab.
Exactly.
And what you can offer is you can get your standard package, or you can get the big one.
Exactly, and that's
So that was, I learned that from the investigators that we also discussed after your hotline, that made it easier to recruit participants in the trial.
exactly.
Now, we're talking influenza, and we're talking events, and we are talking cardiovascular events. But why does it work if it works?
Yeah, so something that was very interesting that we saw in just the DANFLU-1 trial was that we had a very, very late peak in influenza circulation compared to what we usually see. And actually, from publications from the Danish SSI, the CDC in Denmark, it showed that there was almost no vaccine effectiveness against the circulating strain at the time. So that might mean that the vaccination can actually cause a benefit that is not just mediated through preventing influenza infection, but through some of the immunomodulatory effects that you also alluded to during your talk.
So at least we can say we need to up the influenza vaccine uptake. It is still, I believe, around less than 50% in risk groups in Denmark as well. The EU average, as we discussed in your hotline, is 46%, and the EU goal is 75%. But it's another aspect of all this is, of course, that if influenza vaccine in the general population, in patients with cardiovascular disease, doesn't work from protecting against influenza, but something else, should you conduct your mega trial? I hope you get the permission and the funding. Should you conduct it all year?
Yeah, that's a great question, and actually at the symposium yesterday about flu and cardiovascular disease, we had the exact same discussion, and I know from that symposium that an investigator from Australia, they're planning to do exactly that, randomize year round, because they believe, as Niklas alluded to, that there might be these other effects of getting your immune system boosted even more with the high dose vaccine. So that's an excellent question. But and now, if we go on to do it, completely outside the nationwide vaccine strategy, it would probably be at least more possible to do it year round than just doing it during the vaccine season.
Yeah. We should wrap up here. Thank you very much to Niklas and Thor for the fantastic trial you just presented today, showing that it is feasible to conduct a huge pragmatic trial with a simple drug or vaccination in a very short time. So congratulations to your results. You can now relax. And thank you all for listening here today. Thank you.